What would compel a veteran neonatologist with 15 years of experience to question everything she thought she understood about newborn medicine? In today's story, you'll discover the case that made me realize some mysteries in the NICU run deeper than any medical textbook could ever explain. But before we dive into this haunting experience, make sure to reach our subscribe to help us next milestone. Drop a comment letting me know what country you're watching from, and stick around until the end because what happened in those final moments still gives me chills. There are certain cases in medicine that fundamentally alter your perspective on life, death, and the delicate space between them. After carrying this experience with me for 2 years, I finally feel ready to share what happened during those 7 days in September that challenged every scientific principle I held sacred. My name is Dr. Sarah Martinez, and I've dedicated my career to caring for the most vulnerable patients in our hospital system. For over a decade, I've worked in the neonatal intensive care unit at Children's Memorial Hospital, witnessing miracles and tragedies in equal measure. I thought I had seen everything the profession could offer, from premature births at 24 weeks to complex congenital conditions that required months of specialized treatment. The case I'm about to describe began on September 12th, a Tuesday morning that started like countless others in my 15-year career. I arrived at Children's Memorial at 6:30 in the morning for my scheduled 12-hour shift, expecting another day of routine rounds, family consultations, and the careful monitoring that defines neonatal medicine. Children's Memorial Hospital serves the entire metropolitan region, with our NICU handling approximately 3,000 admissions annually. Our unit consists of 48 beds arranged in 3 separate wings, each designed for different levels of care intensity. As the senior attending physician, I oversee the most critical cases while supervising residents and collaborating with our multidisciplinary team of specialists. That morning, I was reviewing patient charts when our charge nurse, Michelle Rodriguez, approached with an expression I hadn't seen in years of working together. She carried herself with obvious professionalism, but there was something in her demeanor that immediately caught my attention. Dr. Martinez, we have an unusual admission coming from labor and delivery, Michelle informed me. The baby was born 40 minutes ago, and the delivery team is requesting immediate NICU consultation for reasons difficulty explaining. What they're having kind of complications at. I mentally preparing for asked, already are we looking, I tated before responding. That complications. The baby's vital, another complex case. Michelle, his signs are perfect is the thing, Dr. Martinez. There don't appear to be any medical APGAR scores were 9 and 10, and all initial assessments show a completely healthy full-term infant. But the entire delivery team is requesting that we take over care immediately. This was highly unusual. Healthy newborns typically remained with their mothers for bonding and initial care, only coming to our unit when specific medical interventions were required. For an entire delivery team to request immediate NICU transfer of a healthy baby suggested circumstances that went beyond standard medical protocols. Have the parents consented to NICU admission? I inquired. The mother is requesting it, Michelle replied. She's asking that we take the baby as soon as possible, and that she not be present during the transfer. I made my way to labor and delivery, where I found Dr. Amanda Foster, one of our most experienced obstetricians, completing her post-delivery documentation. Dr. Foster had delivered thousands of babies throughout her career, and I had never seen her appear as unsettled as she did that morning. Sarah, thank you for coming quickly, so Dr. Foster said. I need to discuss this case with you before you meet the baby. What seems to be the concern, Amanda? The report indicates a healthy full-term delivery. Dr. Foster looked toward the nursery where the infant was being monitored. Sarah, in 22 years of obstetrics, I've never encountered anything like this. The delivery itself was completely normal, But there were aspects of this birth that I can't explain using conventional medical understanding. She pulled up the delivery notes on her tablet. The mother, Jennifer Collins, is a 28-year-old primigravida with an unremarkable pregnancy history. No complications during gestation, normal prenatal testing, and she went into spontaneous labor at 39 weeks and 4 days. The labor progressed normally, and the baby was delivered vaginally after 6 hours of active labor. This all sounds routine, I observed. What makes this case unusual? Dr. Foster paused before continuing. Sarah, during the final stage of delivery, something happened that I've never witnessed the baby was crowd before. Hasning, every piece of electronic equipment in the delivery room began malfunctioning simultaneously. The fetal heart monitor showed readings that were medically impossible. The electronic blood pressure cuff began cycling continuously without being activated, and the overhead surgical lights started flickering in a pattern that seemed almost deliberate. Equipment malfunctions aren't uncommon in delivery rooms, I noted. Electronic interference can cause multiple systems to act unpredictably. That's what I initially thought, Dr. Foster replied. But when the baby was fully delivered, all the equipment returned to normal function immediately. Our biomedical engineering team has since tested every piece of equipment in that room, and they can't find any technical problems or explain what caused the simultaneous malfunctions. She continued reviewing her notes. But the equipment issues were just the beginning. During the delivery, the baby never cried, never made any vocal sounds, but was clearly breathing and responsive. Most newborns cry immediately upon delivery as their lungs expand and adjust to breathing air. This baby was completely silent, yet showed all other signs of a healthy birth. Some babies are naturally quieter than others, I suggested, though I was beginning to understand why the delivery team felt uncomfortable. Dr. Foster shook her head. Sarah, this baby wasn't just quiet. The silence was so profound that everyone in the delivery room commented on it. But more disturbing was the baby's behavior immediately after birth. Most newborns show reflexive movements, crying, and general activity as they adjust to their new environment. This baby was completely still, with eyes wide open, appearing to observe everything in the room with what I can only describe as unusual focus for a newborn. I was intrigued despite my natural inclination toward rational medical explanations. Can I examine the baby now? Dr. Foster led me to the nursery, where the infant, now identified as baby Collins, was being monitored by 2 nurses. As we approached the bassinet, I immediately understood why the delivery team had been unsettled. The baby lay perfectly still, eyes open and alert, but with an unusual quality of attention that seemed remarkable for a newborn less than 2 hours old. Most newborns at this stage show reflexive movements, periodic fussiness, and the typical behaviors associated with transitioning to life outside the womb. Baby Collins displayed none of these characteristics, instead maintaining a state of calm alertness that was striking in its intensity. I began my standard newborn examination, checking in lung sounds and ass reflexes. Listening to heart examination was completely normal. The baby's vitalising neurological responses, and there were no signs of distress or were appropriate. Every aspect of the physical signs were perfect. Reflex abnormality. However, as I conducted the examination, I noticed something that made me pause. Throughout the entire assessment, which typically causes newborns to cry or show signs of discomfort, baby Collins remained completely silent and appeared to be watching my every movement with unusual focus. The baby's eyes tracked my movements with a precision that seemed advanced for a newborn less than 3 hours old. Most infants at this stage have limited visual focus and show random eye movements, but baby Collins appeared to be deliberately observing the examination process. Dr. Foster, I need to admit this baby for observation and further evaluation, I decided. While all physical parameters appear normal, the behavioral presentations warrant careful monitoring and additional assessment. As we prepared for the transfer to our NICU, something occurred that would set the tone for the most perplexing week of my medical career. As the transport team prepared to move baby Collins to our unit, every electronic device in the nursery began displaying the same inexplicable behavior we had witnessed in the delivery room. The infant warmer's temperature display started cycling through readings that defied logic, showing temperatures that would be incompatible with life. Yet the baby remained perfectly comfortable and stable. The pulse oximeter, which measures oxygen saturation in the blood, began showing readings that fluctuated wildly between impossible values, despite the baby's obvious healthy breathing and normal skin color. Most disturbing was the cardiac monitor, which started displaying heart rhythms that seemed to respond to some external influence, rather than the baby's actual cardiovascular function. "Dr. Martinez, are you seeing this?" asked Lisa Chen, one of our most experienced NICU nurses who had come to assist with the transfer. I watched as the monitors continued their erratic displays while baby Collins remained completely unaffected, breathing normally and maintaining that same unnaturally alert expression. The moment we lifted the baby from the bassinet to place in the transport incubator, all the equipment immediately returned to normal function. During the short journey from labor and delivery to our NICU, I found myself studying baby Collins more carefully than I had examined any newborn in years. The baby's eyes remained open and seemed to focus on specific points around the transport incubator, moving with deliberate purpose rather than the random eye movements typical of newborns. Most newborns sleep frequently during their first days of life, waking primarily for feeding or when experiencing discomfort. Baby Collins showed no signs of drowsiness or fatigue, maintaining alertness that continues state of quiet to strike me as highly unusual for an infant barely 4 hours old. We arrived at NICU Bay 12, where I had decided to place baby Collins for close observation. As we connected the standard monitoring equipment, I briefed the nursing team about the unusual circumstances surrounding this admission. "Lisa, I want continuous monitoring for the first 24 hours, I instructed. Document any equipment anomalies, no matter how minor they might seem. Also, maintain detailed behavioral observations. Note sleep patterns, feeding responses, and any unusual activity." "Dr. Martinez, what exactly are we watching for?" Lisa asked. I wasn't entirely sure how to answer that question. Honestly, I'm not certain. This case presents characteristics that don't fit standard neonatal patterns, and I want comprehensive documentation of everything we observe. As the day progressed, baby Collins continued to display the same extraordinary alertness. During routine care procedures that typically cause newborns to cry or show signs of distress, this baby remained completely calm and silent, observing everything with those remarkably focused eyes. The nursing staff began commenting on the baby's unusual behavior. Jennifer Hayes, a nurse with over 12 years of NICU experience, approached me during afternoon rounds with obvious concern. "Dr. Martinez, I've been caring for newborns for more than a decade, and I've never encountered anything like baby Collins. The baby hasn't slept since admission, hasn't cried once, and seems to be aware of everything happening in the unit." "What do you mean by aware of everything happening in the unit?" Jennifer glanced toward Bay 12. "Dr. Martinez, when other babies in the unit cry or when alarms sound from different beds, baby Collins turns toward those sounds with what appears to be recognition and understanding. It's like this baby is monitoring the entire NICU environment." This observation was particularly disturbing because newborns typically show limited responses to environmental sounds and have minimal awareness of activities beyond their immediate care. For a baby less than 12 hours old to display such comprehensive environmental awareness suggested neurological development that was far advanced beyond normal parameters. That afternoon, I decided to conduct additional neurological assessments to better understand baby Colin's unusual alertness and responsiveness. I began with standard reflex testing, checking for the primitive reflexes that all healthy newborns should display. The Moro reflex, also known as the startle reflex, is triggered when a newborn experiences a sudden change in position or loud sound. Baby Collins showed no startle response whatsoever, despite multiple attempts to elicit this fundamental newborn reflex. The rooting reflex, which causes newborns to turn their heads toward touch near their mouths, was completely absent. The sucking reflex, essential for feeding, was also missing. These abnormal reflexes are crucial indicators of neurological function in newborns, and their absence typically suggests serious neurological complications. Yet baby Collins showed no other signs of neurological problems. The baby's muscle tone was appropriate, movements were coordinated, and responses to visual stimuli were remarkably advanced for a newborn. I consulted with Dr. Robert Chen, our chief pediatric neurologist, requesting an immediate evaluation of baby Colin's unusual neurological presentation. Dr. Chen arrived within the hour and hissed conducted own comprehensive assessment. After 45 minutes of testing, he approached me with results that contradicted everything we understood about newborn neurological development. "Sarah, this is the most perplexing case I've encountered in 25 years of pediatric neurology. The absence of primitive reflexes would typically indicate severe neurological dysfunction, but this baby demonstrates cognitive responses that are months ahead of normal developmental timelines. What kind of advanced responses are you observing?" Dr. Chen reviewed his notes. "This baby tracks complex visual patterns, responds to verbal communication with appropriate eye contact, and shows recognition of individual voices. These capabilities typically don't develop until babies are several months old. Yet, the absence of basic newborn reflexes suggests serious neurological problems." As evening approached, the nursing staff reported another concerning development. Baby Collins had not shown any interest in feeding since birth, despite being more than 18 hours old. Most newborns begin showing feeding cues within the first few hours of life, and failure to feed can quickly become a serious medical concern. I attempted to offer a bottle to baby Collins, but the baby showed no rooting, sucking, or swallowing responses. However, the baby's hydration status remained normal, and there were no signs of distress or discomfort that would typically accompany feeding difficulties. "Dr. Martinez, how is this baby maintaining normal hydration without any fluid intake?" Lisa asked during evening rounds. That question had been troubling me all day. By all medical standards, baby Collins should be showing signs of dehydration and electrolyte imbalance after nearly 20 hours without feeding. Instead, all laboratory values remained within perfect normal ranges. I ordered comprehensive blood work normalities that would explain the unusual, expecting to find Aben feeding behavior. The results that come status, hours later, DEF assessed the baby's metabol back TUI'd every principle of new, had learnaborn physiology, id throughout my medical training. Baby Collins blue that challenged work revealed results to fundamental principles of newborn physiology. Stable glucose levels were perfectly despite neonatal intake. Elect nutrit. Most significantly, the baby's ANSs remained optimal relite bale. Typically, blue showed markers develop overt chemistry that weeks or not hours. "Dr. Martinez, these lab life, months of results don't make medical sense," reported Dr. Patricia Williams, our chief laboratory technician. "This baby's blood work looks like it belongs to an infant who's been thriving for months, not a newborn who hasn't eaten since birth." I stared at the results, searching for any logical explanation. "Patricia, Could there be contamination in the samples or equipment calibration issues? I've run the tests 3 separate times using different equipment, she replied. The results are consistent across all parameters. This baby's metabolic function is operating at levels I've never seen in a newborn. That second night, I decided to remain in the hospital to observe baby Collins personally. Something about this case demanded my direct attention, and I wanted to witness firsthand the behaviors that had been troubling our nursing staff. At approximately 11:30 p.m., as the NICU settled into its quieter nighttime routine, I positioned myself near Bay 12 to conduct my observations. Baby Collins lay in the bassinet with the same alert expression that had characterized every moment since birth, eyes open and apparently focused on the ceiling. Most newborns spend the majority of their first days sleeping, waking primarily for feeding or when experiencing discomfort. Baby Collins had now been awake for over 36 hours straight, showing no signs of fatigue or the natural sleep cycles that govern newborn behavior. As I watched, something extraordinary occurred that would fundamentally alter my understanding of this case. Baby Collins began moving in ways that defied normal newborn motor development. The movements were subtle at first, precise finger gestures and deliberate head positioning that suggested intentional rather than reflexive behavior. Newborns typically display random, uncoordinated movements as their nervous systems adjust to life outside the womb. Baby Collins' movements appeared purposeful and controlled. More disturbing was what happened next. Baby Collins turned toward me with direct eye contact that lasted for several uninterrupted minutes. The intensity of that gaze was unlike anything I had experienced with thousands of newborns throughout my career. It felt as though this baby was studying me with the same scientific curiosity that I was applying to the case. "Dr. Martinez, are you seeing this too?" whispered Karen Thompson, the night nurse assigned to Baby Collins' care. I nodded, unable to find words for what we were witnessing. Baby Collins continued maintaining eye contact while making subtle movements that seemed almost communicative in nature. Then, at exactly midnight, every electronic device in our NICU began exhibiting the same inexplicable behavior we had observed during delivery. Heart monitors displayed impossible rhythms. Ventilators cycled without patient connections, and medication pumps activated despite being turned off. The equipment malfunctions weren't random or chaotic. They followed distinct patterns that seemed almost deliberately orchestrated. Alarms sounded in sequence across different beds, creating what could only be described as a rhythmic pattern that filled the entire unit. Throughout this electronic symphony, Baby Collins remained perfectly calm, watching the chaos unfold with that same unnaturally alert expression. Other babies in the unit became restless and began crying, but Baby Collins observed the disturbance with apparent fascination rather than distress. "Dr. Martinez, should I call security?" Karen asked, clearly shaken by what we were witnessing. Before I could respond, Baby Collins made a sound that stopped both of us in our tracks. It wasn't crying or the typical vocalizations expected from newborns. Instead, it was a clear, melodic tone that seemed to resonate throughout the NICU. The moment that sound began, all the equipment malfunctions ceased immediately. Monitors returned to normal function, alarms stopped sounding, and the unit returned to its usual quiet nighttime atmosphere. Baby Collins continued producing the melodic tone for approximately 30 seconds before returning to the profound silence that had characterized every moment since birth. Karen and I stood motionless, trying to process what we had just experienced. The sound produced by Baby Collins had been unlike anything either of us had heard from a newborn. It possessed a quality that seemed almost musical in its complexity and precision. "I need to document this immediately," I told Karen. "Please note the exact time and duration of both the equipment anomalies and the vocalization from Baby Collins." "Dr. Martinez, what do you think is happening here?" Karen asked. I wish I knew, I replied honestly. This case is presenting characteristics that fall completely outside normal medical parameters. The following morning, I convened an emergency consultation with our hospital's most experienced specialists. I invited Dr. Chen from neurology, Dr. Foster from obstetrics, our chief pediatrician Dr. Michael Rodriguez, and Dr. Jennifer Adams, our hospital's consulting psychiatrist who specialized in unusual pediatric cases. As I presented the case details to this assembled team, I could see the same expressions of bewilderment that I had been experiencing. Each specialist contributed their expertise, but none could provide explanations for the constellation of unusual behaviors we were documenting. Dr. Rodriguez spoke first. Sarah, I've been practicing pediatric medicine for 30 years, and I've never encountered a case that challenges basic physiological principles the way this one does. A newborn cannot survive without nutrition for this extended period while maintaining perfect health parameters. Dr. Adams added her perspective. From a developmental psychology standpoint, the cognitive responses you're describing suggest awareness levels that don't typically emerge until several months of age. Yet the absence of primitive reflexes indicates serious neurological dysfunction. These observations are mutually contradictory. Dr. Chen reviewed his notes from the previous day's examination. I've been considering the possibility of an extremely rare neurological condition, but every test we've conducted shows perfect brain function. The EEG patterns are unlike anything in medical literature, showing electrical activity that appears more complex than what we see in typical newborns. What kind of complex electrical activity? I inquired. Dr. Chen pulled up brain scan results on his tablet. Sarah, this baby's brain shows patterns of electrical activity that suggest processing capabilities far beyond normal newborn parameters. The neural pathways appear to be functioning at levels we typically associate with much more mature nervous systems. Dr. Foster contributed her observations from the delivery. The equipment malfunctions during birth and the subsequent incidents in your NICU suggest some kind of electromagnetic influence that we can't explain. I've delivered thousands of babies, and I've never seen electronic equipment respond to a newborn's presence the way it responds to baby Collins. As our consultation continued, we developed a comprehensive monitoring plan that would document every aspect of baby Collins' condition while ensuring the baby's safety and well-being. We agreed to involve additional specialists and conduct more extensive testing to try to understand this unprecedented case. However, what happened next would make all our careful planning irrelevant and force us to confront possibilities that existed completely outside the boundaries of conventional medical understanding. Baby Collins was about to demonstrate capabilities that would challenge everything we thought we knew about human development and the nature of consciousness itself. That afternoon, as I was reviewing test results in my office, Karen called from the NICU with urgency in her voice that immediately commanded my attention. Dr. Martinez, you need to come to Bay 12 immediately. Baby Collins is doing something that I don't know how to describe, and I think you need to see this for yourself. I rushed to the NICU, my mind racing through possibilities of what could have prompted such urgency from one of our most experienced nurses. Karen had worked in our unit for 8 years, and her calm demeanor under pressure was legendary among the staff. For her to sound genuinely shaken suggested something extraordinary was occurring. As I approached Bay 12, I could see several nurses gathered around baby Collins' bassinet, their faces reflecting a mixture of fascination and concern. The baby lay in the same position as always, perfectly still with those unnaturally alert eyes, but something in the atmosphere felt different. Dr. Martinez, watch the monitors, Karen instructed as I joined the group. I looked at the standard NICU monitoring equipment surrounding baby Collins' bed. The displays appeared normal at first glance, showing stable vital signs and appropriate readings for a healthy newborn. But as I watched more carefully, I began to notice subtle patterns in the data that made no medical sense. The heart rate monitor showed a steady rhythm of exactly 60 beats per minute, which would be dangerously low for any newborn. Yet baby Collins showed no signs of distress, maintained perfect color, and appeared completely comfortable. More disturbing was the precision of that heart rate. It never varied by even a single beat per minute, maintaining mechanical consistency for biological that seemed impossible systems. The respiratory monitor showed similar impossible consistency. Exactly 20 breaths per minute, with each breath cycle lasting precisely 3 seconds. Newborns typically show natural variations in their breathing patterns, but baby Collins displayed respiratory patterns that resembled machine-like precision rather than normal human physiology. But it was the brain activity monitor that provided the most disturbing readings. Dr. Chen had left continuous EEG monitoring in place to track baby Collins' neurological function, and the patterns appearing on screen defied every principle of neuroscience I had learned throughout my career. The brain waves showed complex, organized patterns that seemed to pulse in synchronized waves across different regions of the brain. These weren't the random developing patterns typical of newborn brain activity, but rather sophisticated electrical rhythms that suggested coordinated neural processing at levels far beyond what should be possible in a 3-day-old infant. "Karen, how long have the monitors been showing these patterns?" I asked. "Since about 2 hours ago," she replied. "But Dr. Martinez, that's not the most concerning part. Watch what happens when we try to adjust any of the monitoring equipment." She reached toward the heart rate monitor to adjust the alarm parameters, a routine procedure that nurses perform dozens of times each day. The moment her hand approached the device, the monitor's display began cycling through readings that climbed steadily higher, reaching impossible values that would indicate life-threatening cardiac conditions. Yet, baby Collins remained perfectly calm, showing no signs of distress or cardiovascular compromise. The baby's skin color remained healthy, breathing continued at that unnaturally steady rhythm, and those alert eyes showed no indication of medical emergency. When Karen withdrew her hand from the monitor, the display immediately returned to the steady 60 beats per minute reading. We repeated this test with other monitoring devices, and each piece of equipment responded similarly, displaying impossible readings whenever someone approached, then returning to mechanically precise normal values when left alone. "Dr. Martinez, it's like the equipment is responding to our intentions rather than the baby's actual physiological status," observed Jennifer Walsh, another experienced NICU nurse. This observation struck me as particularly significant because it suggested that the monitoring equipment was somehow detecting and responding to our mental focus or attention rather than measuring actual biological functions. Such a phenomenon would challenge fundamental principles of how medical devices operate and how biological systems function. I decided to conduct a controlled test of this apparent equipment responsiveness. I asked all the nurses to step away from Bay 12, leaving me alone to observe baby Collins and the monitoring equipment without any external influence. For 10 minutes, I simply stood quietly beside the bassinet, making no attempts to touch or adjust any equipment. During this period, all monitors maintained their impulse readings. Then, equally consistent mentally focused on the heart rate monitor while making no physical movement toward it. The monitor immediately began displaying erratic readings, cycling through values that ranged from dangerously low to impossibly high. When I shifted my mental attention to the respiratory monitor, it began showing similar erratic behavior while the heart rate monitor returned to its steady 60 beats per minute. This was medically impossible. Electronic monitoring equipment responds to electrical impulses from the body and electromagnetic interference from other devices. It cannot respond to human thoughts or mental focus. Yet baby Collins seemed to be surrounded by equipment that operated according to principles that existed outside conventional understanding of medical technology. I called Dr. Patricia Williams from our biomedical engineering department to conduct another comprehensive evaluation of all monitoring equipment in Bay 12. I wanted to rule out any technical explanations for what we were witnessing before considering more unusual possibilities. Dr. Williams arrived within 30 minutes and began her systematic evaluation of every device connected to baby Collins. She tested electrical connections, calibrated sensors, and ran diagnostic programs on each piece of equipment. After 2 hours of thorough analysis, she provided results that only deepened the mystery. "Dr. Martinez, every piece of equipment in this bay is functioning perfectly, according to all technical specifications," she reported. "The calibration is precise, electrical connections are secure, and diagnostic tests show no abnormalities in any device. From an engineering perspective, these monitors should be providing completely accurate readings. But the readings we're observing are medically impossible," I pointed out. "I understand that," Dr. Williams replied, "but I can only evaluate the equipment itself, and all of it is working exactly as designed. If the readings don't match medical expectations, the cause lies somewhere outside the technical specifications of these devices." As afternoon progressed into evening, baby Collins continued displaying the same unprecedented combination of perfect health and impossible monitoring readings. The baby had now gone 4 full days without any nutritional intake while maintaining ideal hydration, perfect blood chemistry, and stable vital signs that defied physiological possibility. Dr. Chen returned for his evening neurological assessment and immediately noticed changes in baby Collins' brain activity patterns. The EEG readings showed even more complex electrical activity, with synchronized wave patterns that seemed to cycle through different phases in precise timing intervals. "Sarah, this brain activity is unlike anything in medical literature," Dr. Chen informed me. "The electrical patterns suggest neural processing at levels that shouldn't be possible in such a young nervous system. But more concerning is that these patterns appear to be influencing the electromagnetic environment around the baby." "What do you mean by influencing the electromagnetic environment?" Dr. Chen showed me readings from specialized equipment he had brought to measure electromagnetic fields around Bay 12. The data showed electromagnetic fluctuations that corresponded directly with changes in baby Collins' brainwave patterns. This suggests that this baby's neurological activity is generating electromagnetic fields strong enough to affect nearby electronic equipment, Dr. Chen explained. Such electromagnetic generation from human brain activity is theoretically possible, but has never been documented at these intensity levels. That evening, I made the decision to remain in the NICU overnight again, determined to document any unusual activity that occurred during the quieter nighttime hours. I had arranged for additional monitoring equipment to record electromagnetic fields, sound levels, and environmental conditions throughout the night. Baby Collins was transferred to a specialized research facility the following week, where teams of scientists continue studying this unprecedented case. To this day, no medical explanation has been found for what we witnessed during those 7 days. Some mysteries in medicine remind us that human consciousness and development may operate according to principles we have yet to understand. This case fundamentally changed how I approach the practice of neonatal medicine, teaching me that the boundaries between science and the inexplicable are far thinner than we might believe.